and we'll welcome our other participants when they join us. So, good afternoon, everybody, and welcome to the 64th installment of Mrftt HIV STI Echo. Thank you again for taking time out of busy day to spend some time with us. I hope we all learned something today. And we all value your presence. I'm Dr. Boyce, as I said. This is Dr. Musa with me in the room, just off to my right. And today we're going to discuss, at least on the didactic part, a topic that I've been seeing more and more as time goes on, this issue of fatty liver disease and HIV. And I think part of the reason why it is becoming more topic of conversation is that we don't fully understand the relationship between the virus itself, treatments for the virus, how the effects of the virus on the human body contribute to fatty liver disease. What we are seeing is more and more fatty liver disease, not just among persons with HIV, but all over the world. It is contributing significantly to liver-related or non-liver-related morbidity and mortality and transplantation need. And I think the better you understand how this disease works, one, the better clinical outcomes you will have long-term, because remember, we're in a 3 to 4 decade game in terms of keeping our patients well and in good health. And secondly, the better HIV programs and public health specialists can put systems in place to manage some of these long-term chronic comorbidities when it comes to HIV infection. So that being said, let me just pull up today's presentation. I hope this goes well. Excuse me. Of course, the technology is not cooperating, as usual. All right, here we go. All right, here we go. We're good to go. So we'll talk about fatty liver disease and HIV today. So we just put technology support on both ITEC and the University of New Mexico in helping us setting up our own installation of echo programs in Mrftt. So I have nothing to disclose, and we're going to essentially just two things. We'll talk about the epidemiology, the pathogenesis, and the risk factors for non-alcoholic fatty liver disease among persons living with HIV. I'm going to discuss the diagnosis and treatment of NAFLD among persons living with HIV. So first thing, let's talk about what we mean when we talk about fatty liver. So fatty liver means hepatic steatosis, meaning any infiltration of fat into the hepatocytes, the liver cells themselves. And it can be caused by a variety of agents, primary among which is alcohol, which is why there's a distinction between alcoholic fatty liver disease, which in and of itself is a disease entity, and non-alcoholic fatty liver disease. So what we're going to focus on today is non-alcoholic fatty liver disease, which by definition is fatty liver disease that is not significantly contributed to by alcohol use or alcohol misuse. And how we tease the two apart is essentially, a lot of it is based on history, because the manifestations and the biopsy findings are very much similar to alcoholic liver disease and fatty liver disease from other sources. So in terms of what cutoff we would use, so in a female, less than 14 standard units a week, or a male, not less than 21 standard alcohol units a week, should not, we expect, trigger significant fatty liver disease from an alcohol standpoint. So if you have a patient who does consume alcohol from time to time but is a light drinker and has evidence of hepatic steatosis, then we know it's not from the alcohol, it's some other cause. And the term non-alcoholic fatty liver disease is an umbrella term. It covers two conditions, not more than two conditions actually. So hepatic steatosis, which is fat infiltration of fat into hepatocytes, fatty liver itself, without inflammation, and then non-alcoholic steatohepatitis, which means fatty infiltrates plus inflammation. And this is the form of disease that can progress to fibrosis, to cirrhosis, and stage liver disease, and death as a result. So, in terms of how chronic liver disease is affecting persons living with HIV all over the world, liver disease is now the second most common non-AIDS cause of death among persons living with HIV in the world. Not specifically hepatic steatosis, but whether it's hepatocellular carcinoma or HCV-related disease, but liver disease in general is second behind cardiovascular disease as a cause of death among persons living with HIV. And fatty liver disease, from whatever cause, among persons living with HIV and HIV-negative, is now the second most common indication for liver transplantation in the US after hepatitis C infection. Now, while hepatitis C infection is less common, because there's so much fatty liver disease in the population, even though it's happening at relatively lower rates, it is such a large population of people so affected that it contributes to a large disease burden. So roughly 1 in 3 of all Americans have some form of fatty liver disease. And there's a 25% global prevalence over the world, depending on which population you study and how you study them. The prevalence tends to vary. Among persons with HIV, the estimates are somewhere between 1 in 4 and 3%, that's the 2 in 5. That's for fatty liver disease. Of that, 20 to 63%, so 1/5 to almost 2/3, have steatohepatitis, and of those, 40 to 63% have steatohepatitis with fibrosis, which is already on the continuum towards cirrhosis and end-stage liver disease. So what does the pathogenesis look like? So we have this chart here, essentially from normal liver to end-stage liver disease. So on this continuum, first you would see on a microscope, let's say you do a liver biopsy, you see these fat inclusions and gradually get larger and larger, and cause ballooning of the liver cells. That is injurious to the cells themselves and can cause cell death. That triggers an inflammatory reaction. So again, when you look on the microscope, you see these inflammatory cells, and that is diagnostic of NASH, steatohepatitis. As the disease progresses, you get more and more fibrosis, and you see larger fibrotic bands. The liver itself starts to anatomically deform. You actually see the gross changes in the liver. And then finally, we go to cirrhosis, where most of the liver parenchyma is replaced by a mixture of fibrotic and inflammatory cells. And as well, long-standing inflammation over a long period of time can progress to hepatocellular carcinoma. And so let's talk about what the risk factors are in a person with HIV for developing fatty liver disease. So let's talk about host factors. It is found in older persons have a higher preponderance of fatty liver disease. There are some racial and ethnic predispositions, primarily based around genetic changes, some single nucleotide polymorphisms in a particular gene, the PNP and the 3G. And it so happens that genetic mutation is distributed in various proportions in different ethnic groups. Obesity is a major risk factor for fatty liver disease, both among persons who are HIV positive and HIV negative. And also, we see insulin resistance, diabetes, hypertension, dyslipidemia. Now, if you think of the last couple of things we spoke about, obesity, insulin resistance, or diabetes, hypertension, dyslipidemia, remember from medical school days, that is descriptive of the metabolic syndrome. And in a real sense, fatty liver disease is thought of as the hepatic manifestation of metabolic syndrome, but it also works both ways. That in someone who develops fatty liver disease, let's say in isolation, they have a higher risk of subsequently developing cardiometabolic disease, the metabolic syndrome. And actually, fatty liver disease is an independent risk factor for cardiovascular death and all-cause mortality. So the highest cause of death among persons with fatty liver disease is not liver disease, it's actually cardiovascular disease because of the interplay between all these cardiometabolic factors and fatty liver disease. So that's one of the things that is under intense research, trying to understand how all these metabolic factors, including liver disease, play in not just in persons with HIV, but particularly in persons with HIV. Because as we know, our HIV population is aging. I think in the United States, half of all persons with HIV are 50 plus. So we need to understand all these issues as we know all patients who start on treatment should expect to have long lives. Or do we fully understand what they're running into as they get older with all these chronic comorbidities with age? In terms of some of the HIV-related factors contributing to fatty liver disease, antiretrovirals are both new and old known causes of fatty liver disease. Let me explain. We are aware of some of the older HIV drugs like the so-called D drugs, the drugs that thankfully are in very infrequent use, if at all anymore. So the didanosines, the D40, which is targeted, even ACT to a certain extent, zalcitabine, I think, which is DDC, which has been out of clinical use in a very long time, but very toxic. So they cause mitochondrial toxicity, they cause lipodystrophy, lipoatrophy, and we understand that those effects, in terms of how they affect adipocyte metabolism, how they affect visceral adiposity, have a direct impact on fatty liver disease. But one of the things we're understanding newly now is that, especially with some of the integrase inhibitors, that we are seeing a lot of weight gain in persons who are on some of the new integrase inhibitors. And we already knew from what I just said that obesity and high BMI is related to fatty liver disease. So there has been some work with raltegravir initially in terms of how switching from fibrins to raltegravir or vice versa affects hepatic fat accumulation. And as we are now in an era where we are switching in most countries to integrase-based regimens as first-line therapy in HIV, we need to understand a little bit better how integrase inhibitors play into the development of fatty liver disease over time. Now, I mentioned the old nucleoside NRTIs like didanosine and staphyline, but also some of the older protease inhibitors, again, some of which are not in use, most of which are not in use, like indinavirs and nelfinavirs. There are still patients in clinical care who were on some of these protease inhibitors for a very long time and would have developed the so-called buffalo hum, the prick's belly, a lot of visceral adiposity that has been shown to contribute to fatty liver disease in a way that BMI does not always completely capture. In addition to all these other the treatment effects on fatty liver disease, you have to think about HIV as a pro-inflammatory state. You have to think about what whole leaky gut syndrome, so bacterial translocation from the large intestine. The original sin of HIV infection is what it does to your gut. And the initial insult to the immune system in the gut does not correct with immune reconstitution and even prolonged antiretroviral therapy. The changes are permanent. So in addition to the fact that immune surveillance in the gut is reduced, you also get a change in bacterial flora, so-called dysbiosis. And those two things together mean that you get increased transit of bacteria and bacterial products like lipopolysaccharide into the circulation, particularly heading towards the liver, where it causes activation of Kupffer cells and stellate cells and other immune cells in the liver. And that chronic inflammatory process going on in the liver contributes towards the process that winds up as fatty liver. And other viral proteins, specifically HCV, also by way of causing resistance, as well as chronic inflammation, contributes to the development of fatty liver disease. And the final common pathway is fat accumulation or steatosis, necroinflammation, which means inflammation and cell death. And as we spoke to just now, stellate cell activation that causes progressive fibrosis, cirrhosis, and end-stage liver disease. So what is the difference between what's called primary non-alcoholic fatty liver disease and HIV-associated non-alcoholic fatty liver disease? So the prevalence is between 25 and 30% each side. It is not completely clear that HIV is an independent risk factor when you tease out everything else, but there is some work suggesting that it may be. In terms of the risk factors, they are similar in both sides: obesity, diabetes, dyslipidemia, metabolic syndrome. But in persons with HIV, there is this what's called lean non-alcoholic liver disease, meaning persons with HIV would have equivalent rates and more advanced stages of fatty liver disease at lower BMIs. So the implication would be that if you're calculating in terms of what is the risk of this person having fatty liver disease, if BMI is 28, 29. In a person with HIV, that is more of a risk than a person who is. In addition, persons with HIV tend to have a faster progression to cell hepatitis and end-stage liver disease. And we already spoke about some of the early generation protease inhibitors and the older drugs. The prevalence is slightly higher at least based on actual biopsy in persons with HIV versus persons who are HIV negative. And the rate of progression is, in persons who have non-HIV related fatty liver disease, it's about 1 stage in 7 for steatohepatitis in about 1/3 of patients who are affected with primary disease. As we said before, in terms of long-term outcomes, there is increasing evidence that fatty liver disease is an independent risk factor for cardiovascular death, but it is improperly studied. There's a lot of room for accumulation of data in this regard to figure out how we program what we need to do. Do we need to screen? Do we need to prophylax? When do we intervene? So in terms of some of the clinical features of fatty liver disease, first things first, was always think about excluding drug iatrogenic causes and other diagnoses, for example, alcohol abuse or hepatitis C or Wilson's disease or A-beta lipoproteinemia, total parenteral nutrition. There are lots of reasons why we get potential fat accumulation in the liver. In terms of some of the drugs that can do it, Mrftt can do it, tamoxifen can do it, some steroids can do it. So we have to make sure we take a proper history and consider other differential diagnoses before we get to a conclusion. This is primary non-alcoholic fatty liver disease. It is generally asymptomatic, except in advanced cases. Most times, persons who are diagnosed are so diagnosed by accident. So, for example, let's say doing annual bloods in one of our patients, the liver enzymes are a little bit elevated, persistently a little elevated. That might trigger a consideration of fatty liver disease, even though the person is totally fine and has no symptoms whatsoever. Or during ultrasound for, let's say, some other condition, the ultrasonographer reports that the liver is slightly enlarged and the texture is different. We've seen cases of like at all clinically. If there are any symptoms, fatigue is common but non-specific. There's so many other causes of fatigue. And in terms of the clinical findings tend to be that of the underlying predisposing factors. So, for example, the features of metabolic syndrome, obesity, hypertension, that sort of thing. hepatomegaly is variable and not a consistent finding in fatty liver disease. In advanced cases, you may find stigmata of chronic liver disease, so pulmonary edema, spina nevi, jaundice, asterisis, lots of secondary sexual characteristics. In terms of non-invasive testing that might push us in the direction of fatty liver disease, so some transaminases, elevated transaminases are commonly used as a diagnostic tool, but sensitivity and specificity vary, and it's not a reliable indicator because, again, so many different things can cause perturbations in transaminase level. That being said, in fatty liver disease, it's usually less
I'm not sure if I have logged out or if they have stopped. Greg, did we lose you there for a bit?
Yeah, I think we just disappeared. I guess we're back.
Okay,
I think
great.
I'm quite short. Just everything just vanished for a second. I think, are you still co-host? Yes? Okay, yes. All right. All right, so let's continue where I left off. Let's see. Go back to where I left off. All right, so show that.
And while we're waiting, let me take this opportunity to welcome those new persons who have come in. If you haven't put your information for us in the chat box, please do so we know the treatment site you're from and what your occupation is. Thanks so much. Go ahead, Greg.
So I think when the connection went down, we were at a point where we were having a conversation about the fact that in either fatty liver, not fatty liver, and in sometimes advanced steatohepatitis and cirrhosis, liver enzymes may be normal. Right? So one of the other non-invasive ways to try to assess, not necessarily specifically fatty liver disease, but to assess the extent of fibrosis, there are a couple lab assays we can do. There is one called fibrosis 4, FIB4, where it's 4 things under consideration: a person's age, their transaminase levels, and their platelet count. And based on when you put all the things into the formula and the results you get, the lower the result is, especially with less than 1.45, negative predictive value is 90%. So if you put in those values and come up with a low value, you're not likely to have significant advanced fibrosis. And a score greater than 3.25 is about 97% specific, about has a 65% positive predictive value for advanced fibrosis. I think the cutoff whereby one might consider referring to hepatologists for further evaluation is around about 2.6, 2.7. There's also a NAFLD fibrosis score, and it's a composite score of age, blood sugar, body mass index, platelet count, albumin, the transaminase ratios as well. And it independently identifies, in the context of someone who has already been diagnosed with fatty liver disease, whether that person has or does not have advanced fibrosis. There's also a simple calculation, APRI, which is the aspartate transaminase or AST to platelet ratio. And it can give a reasonable idea as to whether or not this person has significant fibrosis or cirrhosis. In terms of imaging studies, conventional ultrasound is often used, and sometimes that's how we diagnose our cases with fatty liver disease, because this is widely available, generally centrally accessible, relatively cheap compared to some of the other imaging modalities. The characteristic findings that is the liver just appears bright on an ultrasound compared to the indicative of the diffuse filtration process, and also attenuation vascular blurring. But the sensitivity can be variable, specificity above 80% in most cases, but it can be more sensitive but less specific. So, for example, someone with, let's say, a diffuse hepatitis versus fatty liver disease, how do you necessarily differentiate the two and that sort of thing? There's another ultrasound-based process called transient elastography, so-called fibroscan, but essentially it uses ultrasound technique to assess liver stiffness, and using liver stiffness as a proxy for fibrosis. But that in and of itself is also not specific for fatty liver disease. It's just an indicator as to how much fibrosis is there, and that may guide therapeutic choices moving forward. CT is also used, especially contrast CT with certain modification protocol can be up to 93% sensitive and specific. And it is better than ultrasound in detecting focal disease. Ultrasound is better for detecting diffuse disease that involves the entire organ. CT will detect small areas of fatty liver infiltration, better than ultrasound. MRI, there's both conventional MRI that we use to diagnose disease, as well as MRI elastography, which is in the same sort of way as the ultrasound-based elastography process, will be used to assess the extent of fibrosis in the liver. And as with CT, it's more useful in patchy disease. So in terms of so the techniques we spoke about earlier were non-invasive means of trying to achieve a diagnosis of fatty liver disease. All of that is essentially to see whether or not we can make a diagnosis of fatty liver without a liver biopsy. Now, there is an ongoing debate as to whether or not liver biopsy is necessarily useful in every single case of fatty liver disease if the information you thereby gain is not going to trigger a change in management. Some of the arguments that they have pro liver biopsy is that in a significant proportion of cases, the performance of liver biopsy changes the diagnosis. And that can be as high as 1 in 5. Right? That if you think it's fatty liver disease, and instead it's autoimmune hepatitis or something like that. So, additionally, remember that, for example, you can have patients with normal ultrasound findings, normal blood work, who still have ongoing disease. In which case, the biopsy makes the diagnosis, and everywhere where everything else fails. And the biopsy is the only way to tell between fatty liver disease and steatohepatitis. Right? And one is non-inflammatory, the other one is inflammatory and progressive. So, in terms of the indication for doing a biopsy, you think about doing that if you have a high suspicion for steatohepatitis, right? You have enzymes going up. If you have suspicion that this person has advanced liver disease and needs to characterize that liver disease, or if you're not sure what the diagnosis, the biopsy will make it. So what do we do about fatty liver disease? So step one, and this goes back to the earlier conversation about pathogenesis and the role of antiretroviral therapy potentially in affecting the natural history of fatty liver disease, is careful selection of antiretroviral therapy. We have so many much better agents than we used to have. And obviously, we're not going back to some of those older drugs, but given the ongoing conversation about weight gain, so for example, if you had someone who had a BMI of 40 and hypertriglyceridemia and hypertensive and diabetic, what would your antiretroviral choice look like if you wanted to make sure this person doesn't end up developing fatty liver disease or worsening fatty liver disease, particularly given the question about weight gain integration. Is an integration inhibitor necessarily the best choice? I think that's an ongoing debate right now. In terms of dealing with fatty liver disease, one of the first things you have to do when someone who has metabolic syndrome that is driving a fatty liver disease, deal with the metabolic syndrome. So a weight loss of 7 to 10% can actually cause regression of fatty liver disease and improvement in fibrosis. Statin use as indicated, metformin use, both of which are safe in fatty liver disease. And diet and exercise, a mixture of both aerobic and resistance exercise, about 150 to 250 minutes a week. In terms of specific drug treatments, there are a couple agents that have been evaluated. So tesamorelin, which is a growth hormone receptor hormone analog, a growth hormone releasing hormone, analog, because they have found that there's a deficiency in growth hormone release in persons who are so advanced, so affected by fatty liver disease, and it's actually FDA approved for management of HIV-associated lipodystrophy, and there is evidence of benefit in persons who have fatty liver disease. Vitamin E at a dose of 800 units for about 96 weeks. In non-diabetic patients, it has been shown to improve the histology, less fibrosis, less inflammation, but there is a possible increased risk of prostate cancer, so they would have to balance the risk with the benefits. Also, pioglitazone at a dose of 45 milligrams a day for a year and a half, roughly, in diabetic patients has been also shown to be of benefit, but some of those drugs in this class have the potential for causing weight gain, which is exactly what we don't want, causing congestive heart failure, and as well as a potential risk of bladder cancer as well. In terms of some of the other more recently developed drugs, so cenicriviroc, which is similar to maraviroc, which some of us remember that good old CCR5 inhibitor. So cenicriviroc is both CCR2 and CCR5 receptor antagonists, because they actually found that the CCR2 and CCR5 receptors were overexpressed in steatohepatitis, and it was actually found by accident when they were doing the investigations around the usefulness of this drug as an antiretroviral agent, that they realized that persons who had fatty liver disease, their liver enzymes were going down and their fibrosis markers were improving, so incidentally. So this is another indication, particularly potentially for this drug. But in someone living with HIV, they would also have to be on suppressive antiretroviral therapy. Otherwise, they would just develop CCR5 resistance. Aramcol, which is a fatty acid bile conjugate, the findings have been mixed. So it did reduce liver fat in a small study of persons who were HIV negative, but there was no benefits over placebo in another small study in persons who were HIV positive. So it's a little equivocal right now as in the use of this agent. So in conclusion, fatty liver disease is increasingly recognized as a major cause of morbidity and mortality among persons living with HIV. Early recognition and intervention is essential to avoid severe outcomes and premature death. And the role of no antiretroviral agents and weight gain in relation to their impact on fatty liver disease is under active investigation. I'll leave it there. Thank you very much. And I'll open the floor for any questions or comments anyone might have.
Ooh.
Very quiet.
Yeah.
All right.
Thank you for the great presentation, which has left me with a few more problems than solutions. Given the fact that we embraced the arrival of TLD and felt very happy, but it seems like in the long term, we don't know what we are facing. Reminds me of one of our patients who called me today that he read about dolutegravir and it has so many side effects, including the liver, that he's scared of taking it and is ready to go back to his Biktarvy. But checking on Biktarvy, it also has similar problems with the liver. So like some lecturer said one time, it's basically wait and see what will happen, especially in this world where we have obesity is becoming the norm and normal size is becoming the abnormal.
All right. Okay, so let's pull up the case and look. Okay, so we will have Dr. Musa present today's clinical case. Thank you so much.
Thanks very much, Dr. Boyce. It will be a relatively short presentation on case 64, MRF 48. And we're presenting a 42-year-old female patient, a resident of Trinidad and Tobago, who joined Medical Research Foundation Clinic way back in 2013. The lady went for a test because she was encouraged by her partner of that time, and then she tested positive. It turned out that the partner who encouraged her to go for the test was HIV negative, and her former partner, who is the father of her 8-year daughter by that time, was also negative. When she came in February 2013, she gave the history of weight loss, estimated at between 20 and 30 pounds. She had slight cough and occasional fever. Of major concern was recurrent abscesses, which she had in the groin, around the axillary areas, which had been there for the last 1 year. And she had stopped using roll-ons a year earlier, but these changes persisted. The other complaint she had on presentation was feeling depressed. She also expressed feeling like committing suicide, but those started only after she found out that she had HIV infection. When we examined her at that time, that was in February 2013, she had multiple relatively firm and inflamed areas around the axilla and groin. All were discharging some pus. All were non-fluctuant. At that time, we thought probably she had a bacterial infection, and she was put on a course of antibiotics consisting of amoxicillin and clavulinic acid. When she came for review 2 weeks later, there was actually no change in terms of the swellings and the pus which was coming from those lesions. Her baseline investigations were as above. Her CD4 cell count was 174. Viral load was just slightly over 100, or over 500,000 copies. Blood sugar was normal. White cell count was normal plus normal distribution. HB was 10.7. She was negative for syphilis, and biochemistry was normal. She was started on treatment with a triplet, and she has maintained undetectable viral load since 2013, and she currently has a CD4 cell count between 600 and 700. The abscesses did not improve despite antibiotics, and she was referred for surgical review in February 2013. And at that point, she was given an appointment in June 2013, and then she was given doxycycline, 100 milligrams twice a day for 2 weeks. Again, when she came back, she reported there was no change in terms of the lesions. Our patient was reviewed in the plastic surgical unit, and she had some surgery in the axillary region, which debrided the lesions. And then she was referred to Eric Williams Medical Sciences Complex surgical team for further management of inguinal lesions, and plus some lesions she had in the inguinal area. While being tossed between porous pain plastic surgery unit and general surgical unit at Mount Hope, the patient reports that at one point she listened and heard some bitter confrontation between the two surgeons about her care. And to date, she has not heard any further surgical intervention. Now, these are some of the lesions that she has currently. Unfortunately, I did not take a picture when I saw the first time in 2013. Next. After she had surgical intervention at the plastic surgical unit, she only has a small lesion which doesn't bother her any much on the right side of the axilla. Next. That is what she has now on the left side of the axilla, which was all kind of had multiple nodular lesions which were discharging pus. Now, this is a picture from a different patient with the same condition, and it just shows you how bad the lesions can be with or without intervention. Now, our patient has been on a number of medications. She's been on antibiotics, especially doxycycline, for a very long time, so she says. She has been on prednisolone for a long time also. She has had multiple doses of augmentin. She's been on analgesics, but the lesions have not healed at all. Now, before I pose the questions, the problem with this lady's condition is that one, it is recurrent. Two, the cause is often not known. Three, well, there have been a few reported cases amongst patients who are HIV positive. It doesn't seem to be more predominant amongst the HIV positive patients vis-a-vis HIV negative. It is reported that some cases do run in families. It's relatively more common in females than males. Now, as I've said, this is a patient who, from MRF point of view, is doing very well on antiretrovirals. She's been on antibiotics and steroids for years without much improvement. The only time she had hope and positive one was when she was attended to by the plastic surgical team when she had surgical intervention, and the lesions in the axillary regions have healed pretty well. Now, from the interactions she heard between the two surgeons, she feels very strongly that she's not being taken care of properly because of her HIV status. And as I've mentioned, she did very well after surgery. Now the question raised really, what other linkages do we have with the other specialties for care of our patients? Because this is something which comes on and off. There are times patients go for care, and the moment they mention that they're HIV positive, things disappear. Either the theaters are not operating or the instruments needed are not available. One case in point is one of our patients who has a renal stent for years. Every time she goes for intervention for the removal of the stent, she's put last on the list. And towards the end of the day, either there's an emergency before him, after which the surgery is cancelled, or there's a reason why he can't have the surgery. And this somebody who's been going in and out of Port of Spain General Hospital for a while. The last time I heard about him was at Mount Hope Warden because his renal functions got worse. The other problem is there any other form of treatment for this lady apart from surgical intervention? And last but not least, how much do we stand out for our patients when the standing out is greatly needed? Thank you.
Okay, thank you, Dr. Mrftt.
So any way in which we can help this lady, any other treatment modalities that one could suggest, or any other referral system available so that she could get some help?
I don't have a lot of experience with I don't think that ever, but he would have been ideas as a dermatologist. I had in the last year, 2 patients, both male interestingly, who I diagnosed with the same hidradenitis suppurativa, who had for several years. I just didn't know what it was. I just assumed it was some kind of infection.
Yes.
And when one had an axilla angle, it was so much pain he couldn't sleep. And he was taking diclofenac every day.
Wow.
Problem is that I diagnosed him during COVID, right? Where all the clinics are closed.
Yes.
Right? And I called the consultant, and I think at the time they were seeing like walk-in cases, not using cases. So I asked him to order referral. I asked him to come up, let the referral go there right away. But he lives, because I remember I would drop medication for him somewhere in South Africa. I said, what's that for right now?
Yeah.
It's 1 hour and 45 minutes. It took me less time to get to my arrow. So he is unable to work because of the pain. Right. He's very self-conscious because he has essentially discharging.
Yeah.
And he's since fallen out of care. I think part of it is just the demoralization from the condition. I think I suspect as bad as his disease is, they may have to excise and graft. Because he is essentially down to fascia. Right? He's down to superficial fascia. I don't know if we can engage dermatologists to have them admitted as an emergency to get some kind of care. I think that I suspect because of what's happening with COVID, we will have to resort to that almost, as default, because how else our patient will be seen? I don't know if that at all.
Because when I checked on the condition, one of the, apart from the antibiotics, the antiseptics and the steroids and metformin and so on, if the condition is persistent, like the case you're describing, then surgical intervention is key. And if these ones don't work, then there is also indication for immune modulators, some of which have been reported as being effective in some of these chronic and recurrent cases. Because even for cosmetic reasons, when you imagine a lady with all these sores in the axillary area, which means she cannot wear any sleeveless tops, and she cannot wear any bikinis, even if she was to go to the beach. And then the pain is horrible. So, and with somebody who's taking diclofenac for a long time, we are also risking their kidney functions. And they're demoralized, they're depressed, they probably stop taking their antiretrovirals. It's just spinning in mud. So even if there are not so many, but these are some people who need really care, and they need it. I mean, having those lesions for more than 10 years is quite a bit of something.
I think COVID has made everything more complicated.
Oh, yes.
Because otherwise I would just say, because I've had an interview like this once before. I had a patient who was waiting 2 years for an outpatient clinic appointment for thyroid problem. So I think actually called the quality department in the hospital and complained. This is 2 years for a single appointment. And worked. But I don't know that option is available because what the clinics are closed.
Yeah, the clinics are all closed. They are reopening the theaters. So we pray that soon they will be able to reopen the clinics, because as you said again, there are so many people, but again, there are so many people are waiting to go to the clinics. So even when we open the clinics, the backlog will be quite a bit, and a number of patients, including ours, will still take a much longer time before they're reviewed in the outpatient clinics. And then they don't have situations that are urgent enough that warrant being taken care of as inpatients. Plus, as you said, there are also patients who do not want to hear of anything like going to the hospital because of COVID. So we are kind of caught between a rock and a hard stone.
I know there are some physicians with us from Haiti. Welcome, welcome. I wonder if any of you are able to, if you have any experience with this particular condition, we'd love to hear, get some advice, because it is a very difficult problem to deal with. And oddly enough, I didn't see a single case until I started looking. So I don't know if it is that it's more common among people with HIV. Is there any research that it's not a common condition?
No, it's not actually common amongst people with HIV because there are only kind of single reported cases, like somebody has a report on a Sudanese woman. It was just one case. Somebody has a report from India, but that is more than 10 years ago. So it doesn't seem to be common amongst people who are HIV positive. Now, like our patient, when she presented the first time with the CD4 cell count below 200, one would have thought very easily that this somebody is more prone to infection. So it's just a bacterial infection, you give antibiotics and the CD4 cell count goes up and they get better. But apart from getting better, as far as the CD4 cell count is concerned, because she's actually her CD4 count within 6 months was 200 and above. And then this viral load has remained undetectable since that time. So, and she works and she looks happy, but inwardly she is very sad because of this situation. But it doesn't seem to affect, though it has been reported in HIV positive people, but it doesn't seem to be more prevalent amongst HIV positive than amongst HIV negative people. And it seems as nobody knows exactly what causes this ailment, why women are more prone to it than men is not clear. And strangely enough, some people have even used contraceptives in an attempt to treat it. So whether it's related to some hormonal changes, again, it seems to begin around about puberty and not before, and doesn't seem to occur in menopausal or postmenopausal women. So there could be some little linkage with hormonal changes which haven't been identified. The only other thing I noticed that under a condition that occasionally is related, connected with this is Crohn's disease. Yeah, a few people with Crohn's disease have been reported with adenitis suppurativa. So, but the actual cause is still a mystery.
So, the last part of the question, how do we advocate for a patient? This is, it's not, I wouldn't say a difficult thing, because it's just a simple matter of picking up the phone and calling. But I remember having, for example, in one hospital, one of the doctors refuses to do colonoscopies on HIV positive patients. And the ID specialist had to report him because this could be making discrimination. I've heard horror stories from patients from all over the country.
Yeah.
How certain care efforts deal with them. I mean, something as simple as on the ward doing rounds. And the diagnosis is announced at the top of the, in a booming voice, and everybody in the world suddenly knows. So how?
Actually, yes, because patients still experience very embarrassing moments when they go to the clinics and somebody basically, from their words, sometimes I pray it's not true, somebody shouts within the hearing of virtually everybody about their HIV status. I mean, somebody's diagnosis is private. But like you've said, how do we advocate for our patients? Because sometimes it tends to boil down to personal relationships. For example, before Dr. Daniel died, if I had a patient with a urological issue, I would call him on a personal level and he would pick it up and attend to the patient. But now I don't know anybody in urology like this guy with a stent problem. I mean, he's talked to you, he's talked to me, we know him. But I mean, like Dr. John said, Dr. John from New York, the last time he visited, I don't know what we were talking about. His opinion was he pick the file and walk into the hospital and go to the head of the hospital and tell them what is happening. But how many times are we going to do that? Because even the ladies who get pregnant, some of them don't get the best treatment simply because they're HIV positive. But even HIV positive are entitled to having families. And in the world we live in today, there's no big problem.
So I'm sort of thinking systems right now. Is this a training issue? Is this an education issue? Do I need to start in medical schools? Because I've noticed that all the consultants who have been recently trained, let's say elsewhere, clinical specialists, who train in the UK and Australia and the US, where you can't do that kind of foolishness. You can't think about mistreating someone with HIV because you will lose your job.
True.
It's trained out of it.
Mm-hmm. I mean, some years ago, a registrar in medicine was called to go and review a patient. And he was on call, and he refused. And the director of the hospital made him lose his training and his job very easily. All that he said was that he put it in writing, and that doctor is not going to work in the hospital where I'm the head. Now you can be on the university side, but you can't practice. So he had to leave because he was called to review a patient and he refused. And I mean, I was just wondering last night in my sleep, like, is there a curriculum, is there a topic on HIV in medical school at the West Indies University? Because some universities have incorporated a particular time when the medical students are taught specifically about HIV and AIDS.
I think that because of Edwards had a class every week.
Ah, okay.
And right in this room. So,
all right, okay.
Because that was not there when I graduated.
It's not dermatology.
No, it's just HIV.
Yeah, which is good. Which is good.
So hopefully.
But again, I think the other problem is the refusal by a number of personnel, even medical, to accept and learn a little bit more about HIV. And the case in point is, I know somebody is there from Mount Hope, but the situation where at Mount Hope Hospital, there's an HIV clinic, but most people don't seem to know that it is there. I mean, it doesn't have to be called HIV clinic, but there needs to be awareness so that patients are referred instead of walking around before they find a balance where they can receive treatment.
All right. I'm not sure we solve all the problems with this case, but hopefully we have discussed some of them. You can think about lobbying directly with some of the senior physicians who hopefully will be open to that. I don't know medical if you can do anything else in terms of, because that is all the different medications that she went through.
She's been on that. I mean, unless somebody can put them on these some modulatory medications, if available. I was talking to the pharmacist from St. James, and she told me quite a number of things are not there. So even if, and those medications are damn expensive. And it's not a single dose, it's something that needs to be given on a regular basis.
I think we're just a little bit over time. So, and again, thank you, Dr. Musa, for the case. Thank you, everyone, for your attention. We're always, as I said, welcome and we're honored by your attendance and taking time out of your busy day to be with us. So, from Dr. Boyce and Dr. Musa, thank you for this, the end of the session. Our next session will be in 2 weeks. It will be an STI session from Dr. Edwards, and then hopefully have a psychosocial session. Our new psychologist to get to have a conversation with us. And we shall see you in 2 weeks' time. So again, welcome everyone, and thank you so much. Be safe, be well, and we'll see you next time. Take care.